This is poster 1104, many benefits of Empagliflozin persist in those with reduced renal function. Updated data from the Association of British Clinical Diabetologists Audit Programme, presented by myself, Tom Crabtree, and with special thanks to all ABCD audit contributors. These are my disclosures. The ABCD audit programmes are set up with the aim of establishing real-world data on the use of new diabetes medications and technologies. The Empagliflozin audit was launched in March 2017 and was the last ABCD SGLT2 audit to come into fruition. The aims of this audit, as with all of our audits, was to collect anonymised routine clinical data for patients taking epagliflozin in order to provide real-world and perhaps more generalisable data on its use. Data is received into the audit via three routes, either through primary or secondary care and the online audit tool, or more recently we've received data from primary care in large-scale anonymised datasets via clinical commissioning groups. Mechanistically, SGLT2 inhibitors require relatively intact renal function in order to exert an effect. Data are limited on which beneficial effects, if any, may persist in those with reduced renal function at baseline. Currently, SGLT2 inhibitors are not licensed for use at lower eGFRs. For empagliflozin in the UK, it is recommended not to be commenced in those with an eGFR of less than 60 and to be discontinued in those with an eGFR of less than 45. It should also be noted, however, that in the UK, many medications are used outside of licence, and therefore there's an opportunity to examine the effects of SGLT2 inhibitors in the real world if they're being used in those with reduced eGFRs already. For this analysis, data were extracted from the ABCD audit tool. Those with baseline eGFR values were included in the analysis. For each outcome variable, a minimum dataset of a baseline and follow-up value were required. Of a total of 5,880 patients included, these were then stratified into groups as follows. Analysis was conducted in status 16 using paired t-tests and ANOVA or non-parametric methods if skew dictated. The baseline characteristic of our cohort are displayed here. It is relatively generalisable to a general diabetes population. It should be noted, however, that as eGFR decreases, there is a notable increase in age and duration of diabetes, which does make some sense as those who are more advanced in age or have had longer exposure to diabetes are more likely to have reduced renal functions. The results were as follows. Significant reductions in HbA1c and weight occurred across all groups, although statistically significant differences between groups were also noted. HbA1c reductions appear to be of a lesser magnitude in those with reduced renal function at baseline, although still significant. Significant reductions in blood pressure, both systolic and diastolic, were noted in all groups with an eGFR of greater than 45 at baseline, but not in those with an eGFR of less than 45. This fits with the proposed mechanism of BP lowering action. At lower eGFRs, reduced renal glucose excretion would lead to reduced osmotic diuresis. Assessing some of the other parameters, it's interesting that the decreases appear to be consistent across all levels of CKD. ALT is a good example of this, with comparable reductions in ALT across all groups, although failing to reach significance in the eGFR less than 45 group, perhaps due to lower numbers. In summary, the use of empagliflozin at an eGFR of less than 45 still confers statistically significant HbA1c improvements, although perhaps of a lower magnitude, as well as weight loss. Systolic blood pressure and diastolic blood pressure reductions may be limited and failed to reach statistical significance in those with the most impaired renal function at baseline. Long-term clinical outcomes were not assessed as part of this audit, as that data was not collected. Some limitations of our observational data set is that some confounding variables weren't able to be adjusted for as the data was not available. More evidence is still needed regarding the use of empagliflozin at lower levels of eGFR. Thank you for taking the time to read and listen to this presentation, and the references used in creating this presentation are listed on the final slide.